So also at the Lugano meeting, I gave a talk summarizing some of the results of continuous-based therapies in CLL, and we certainly know patients with CLL can benefit from drugs like ibrutinib, venetoclax, idelalisib, duvelisib. We have a number of these novel agents, and they can be given continuously with very good results. We've seen data now for ibrutinib in 7 years of follow-up, and many of those patients, particularly those treated in the frontline setting, are still on ibrutinib and benefiting from it. So I think particularly for our older CLL population, where we might not need to be maximally aggressive with therapy, a sequential approach of novel agents, for example, starting with ibrutinib and then moving on to other agents is a reasonable strategy. But I also highlighted in my talk that I think particularly for younger patients or those with higher risk disease, we need to be thinking more about combinations of novel agents. And I think that we have a number of promising ones in development. Certainly the venetoclax plus obinutuzumab regimen looks very good for a frontline time-limited therapy. And then we have data that was recently published on ibrutinib plus venetoclax, which also looks great. And I think we're going to have a number of these excellent phase 2 data sets coming along. The challenge is going to be how do they compare to each other? So I think over the next few years, we're going to need to wait for the results of ongoing phase 3 studies to really know how to optimally sequence our therapies for CLL.